I know that you run some of the most successful dermatology conference. You have the winter clinical, you have the fall clinical. You gather lots and lots of great speakers coming and to educate not only the dermatologists but the just MPs and PAs, everything. From your vantage point, what are we doing as a field? What are some of the latest progress and development for management of melanoma? What have you been hearing some of the leaders and some of the experts are talking about melanoma?
That's a great question, Steve. And we always could get better at this. I look back to when I started 40 years ago and the advances that have made over those periods of times. I think the two biggest areas, one I alluded to already, with the fact of immunologic therapy for melanoma. I mean, that's made a real difference where it's not an automatic death sentence. A
Sure.
melanoma the size of a dime on your skin has like a 50% chance of having already spread. So you have to, the fact that there is some treatment for that is great. But more importantly, the advances I see right now are in early detection and using technology to try to help with this. We go back to the ABCDs, where, as I said, 2 years from now will be the 40th anniversary. And there was nothing out there then to do that.
No.
And now some handheld tools. I mean, dermoscopy has made a difference to really help to identify these lesions. But more importantly, we're starting to see a lot of technology, AI kinds of things, artificial intelligence, a variety of other features, looking at the fact that malignant cells have different electrical resistance than benign cells. So there's a device that looks at that. And also looking at other wavelengths beyond the visible things we can see, looking at infrared, looking at ultraviolet, those kinds of things that we can't see with our eyes, but we can be aided with devices to look at that. There's probably 20 different technologies that are being evaluated at this point, literally, to look at this thing. And I don't know which is going to win, but I look back, our mentor, Al Koff, gave me a textbook, a dermatology textbook from 1903. If I look at that, I kind of laugh, how they think, melanoma is caused by bad water and things of that sort. But I know they're going to look at our textbooks from, 40, 50 years from now and say, they actually had to cut these things off before they could make a diagnosis. And all these, I think of, Star Trek or something they put the device on and heal, the electronic device. So there's a lot of energy and a lot of smart people working on these things and working at it for a bunch of different directions. And one of them will be great. I don't know which one it's going to be, but one of those technologies is going to make a big difference, I think.
No, that's a great summary. You covered dermoscopy, right? And you talked about some of the devices with dermoscopy incorporating different wavelength, and you talked about the Nevasense device that is FDA approved to looking at melanoma. We have AI algorithms. We have total body 3D imaging. We have confocal laser microscopy, and you talk about there is this company DermTech to do tape stripping, right? So all those different pieces.
I would add one other thing to that, which is really genomics has made a big difference.
Sure.
That's one of the big areas.
Yeah.
But we talked about DermTech for using genomics for diagnosing melanoma, as well as assessing prognosis with genomics, the Castle test.
Correct.
I think
yep.
That's really made a big difference in our armamentarium of effectively assessing prognosis and diagnosing. So you're going to see more and more of this. What I honestly believe is right now we lump melanoma into one disease. And I think genomics are going to tell us that melanoma is more than one disease. We're going to find different genetic patterns of different melanomas and maybe be able to treat them with more targeted therapy. We're not even close to that yet, but that's my vision of the future.
No, I totally agree with you because we already know, right, the BRAF mutation, 50% of the melanoma because they have the single amino acid change, right? And then we know BAP mutation that give you ocular melanoma. We know NRAS and other type of melanoma give you selective acral melanomas. So you're absolutely right.